Welcome. Hello, everyone, and welcome to Talk Time. I'm Dr. Rebecca Jorgensen, and I have with me here today Dr. Jeremy Safran. And Jeremy, I just want to take, or Dr. Safran, I should probably say, a minute to introduce you to our viewing audience today.
Sure.
You are chair and professor of psychology at the New School for Social Research and former director of clinical psychology. And you just are a vast writer. There's so many publications, over 150 publications on your research. You have a very active lab. You've written a number of books. You're, most recently, I think, the psychoanalyst and psychoanalytic therapies, the psychoanalysis and Buddhism, which is very interesting, and then negotiating the therapeutic Alliance Relational Treatment Guide, which is going to be some of our focus today. And anything else that you want, you've done some DVDs too, training DVDs, but anything else you want folks to know about you as we get started today?
I think that's a pretty good start. Rebecca and I spoke for a few minutes beforehand, but so I won't say hello to her, but hello to all of you who have tuned in. And no, I think that really sort of, thank you for that very nice introduction, Rebecca. And any questions you have, I'd be very happy to answer.
Well, I'd love to hear what your lab is involved in now, kind of what you're doing currently and what you're really excited about right now.
Sure. Well, the major focus of our lab, which right now it's housed at Beth Israel Medical Center in New York, in the brief psychotherapy program, and actually it has been there for the last, since the early 90s. Originally we started in Toronto, at the University of Toronto, Department of Psychiatry, but in 1990, when I moved to New York, myself and a colleague of mine who had originally done a postdoctoral fellowship with me, Chris Moran, we set up the lab at the Brief Psychotherapy Center, and the major focus for the last 25, 30 years has, broadly speaking, been on the topic of ruptures in the therapeutic alliance, how to resolve therapeutic impasses, but then there are a number of other themes, sort of connected with it that, that come out of that, including training therapists, sort of training them, teaching them skills, doing research on what skills are involved in dealing with difficult patients, training therapists to sort of work with their own emotions. So I suppose therapist affect regulation skills would be probably the best way of describing it. I have a long-standing involvement and interest in mindfulness practice of various types, and so we incorporate mindfulness practice into the training of our therapists to help them learn to pay attention to their own experience as it emerges in the moment, and also be able to sort of track the process in the therapeutic relationship with the patient. I suppose the other thing I could say is that I have a background from years ago in the whole experiential therapy tradition. As Rebecca and I were discussing in the early days, I actually, Les Greenberg and I collaborated in the sort of development of the foundations of the whole.
You've written a book with Les, right?
Yeah, we wrote a book. Wrote a number of articles together, but we sort of developed the foundations of the, not the marital aspect of the emotion-focused tradition, but the whole, sort of broad emotion-focused tradition. So I also have that background in the whole experiential tradition, and that still is an important part of what, sort of informs my work and my writing and so on. So there have been many, many influences, including attachment theory and so on. So I mean,
that's been such a fun piece to that we share in common, and the link that you have that I think some of our viewers would be interested to know is that you also were part of Sue Johnson's original research on couple therapy, emotionally focused therapy.
Yeah, so I was telling Rebecca that at the time Sue was doing her dissertation with Les Greenberg, who is colleague, collaborator of mine, and so I actually ended up serving as one of the therapists in the first emotion-focused therapy study, which she conducted at the time with Les Greenberg. I guess at the time that was the one which sort of compared emotion-focused therapy for couples with Neil Jacobson's approach to couples therapy at the time. So I remember it all, sort of quite well in the early discussions taking place in Les's house about, what the manual would look like and so on and so forth. So it was a lot of it was a wonderful experience and very sort of fond memories of the whole time.
Great. Yeah, it's very, very fun and exciting. We certainly have been a watcher and admirer and user of your work, and I think it's so important for therapists that we know some of what you've been researching and studying. And so maybe we could talk a little bit, or maybe a lot, as the case may be, about alliance rupture and also strains. You've studied enough about alliance and rupture, and that you can look at kind of these gradations also of what's happening in the alliance and how to watch for strains maybe to prevent some rupture, as well as how to repair rupture once it happens.
Yeah, absolutely. So I think as you're pointing out, the important thing to bear in mind is that there's a tremendous variation in terms of the sort of intensity and sort of duration of strains or ruptures in the therapeutic alliance, ranging from the more dramatic ruptures in which patients clearly express distress with the therapy or the therapist, lack of progress. In these kinds of situations, it's not unusual for these are the kinds of situations in which therapists tend to respond defensively.
So that would be one marker that therapists can watch for. If they're kind of feeling stuck, or they're feeling in some way that particular clients aren't moving forward, that could be a place to look at alliance right there.
Right. So in some respects, those are the more obvious ones. When the patient is sort of angry at the therapist and expresses it directly, we call that a confrontation rupture. But there are more subtle ones as well, where on the face of things, everything is going smoothly, but if the therapist pays attention, if you pay attention to your intuitions, you have a sense that something feels a little bit funny, and so at times like that, it's worth paying close attention to your feelings, and then sort of checking in with the patient and exploring whether there is something going on in the relationship which perhaps is not being discussed. And often what happens is that patients are very reluctant to express any concerns they have about what's going on in the therapy, or may not even be aware of it. It may be more stylistic for the patient to just kind of sort of defer or comply in relationships with other people. And in those situations, it's really important for the therapist to be able to find skillful ways of being able to attend to those moments and find ways of beginning to explore those moments with the patient and sort of invite them in a kind of collaborative process of exploring what's going on in the therapeutic relationship at times like that.
So there's these, you write about the two kind of broad ways that strains and ruptures show up, with the confrontation ruptures and the withdrawal ruptures. If we were kind of thinking about that in attachment terms and the way people emotionally regulate emotion, we would see that with the, kind of maybe a more anxious type of, coming from the more anxious type of client, attachment style wise, or more insecure avoidant style, right, where they're going into more of a withdrawal rupture. And so those are really, I actually like I don't know if I could say that. So I'm going to say it's I was going to say I like, but I don't think that's the right term. But when you have those confrontation ruptures, you know that it's right there. You know, it's like you said, it's so obvious
Right.
there, and then it's so helpful because you can move right into attending to it, and it doesn't have the same subtlety. In fact, I have some people may have seen it. I have a 10-session series out on emotionally focused therapy. It's just straight therapy, uncut, unedited, 10 sessions with a couple.
Yeah.
And in one of the sessions, the couple came in really high distress. I think it was the second session. And I'd been sitting there, probably not doing session management very well. You know, I was trying to kind of settle things down, and I totally like misattuned with where the husband, the male partner, was. And she had been going on. She was really upset, and he was starting to get defensive, and of course he was more withdrawn. And so by the time he gets defensive, you know, it's really been building up inside of him for a long time. And I was trying to settle it down, and I leaned in and I said, "This is good, you guys. This is good. You know, like I'm getting to see what happens when they get caught in their conflict." And was such a misattunement. He turned at me and said, "No, you know, Rebecca, this is not good." And I went, "What?"
Right.
And of course, as I talk about it, I remember the shame and disruption that happened inside of me and in the moment. But I was so glad that, on the other hand, I was also very glad that he let me know so I could kind of reach in and apologize and try to get back, you know, in sync somehow with him. But
Right.
that confrontation rupture was, I mean, I was able to kind of navigate it. I think I don't know if I should have ever gone back to it. Actually, I was going to ask you what would you recommend to a student in that situation?
Well, you know, so it really depends. You know, sometimes, you know, sort of if there is a rupture, you know, it can be, you know, sort of repaired sufficiently to, you know, if there's another sort of task in therapy that you're engaged in, then there's no need to explore what's going on in the rupture in depth. You know, other times, you know, the rupture becomes so problematic that unless you know, sometimes therapy begins without any kind of therapeutic alliance, and you know,
Yeah.
an important first part of the therapy, you know, and this can go on for, you know, sort of days, weeks, months, involves really sort of trying to, you know, in attachment terms, I guess, establish more of a secure base, but in, you know, therapeutic terms, really sort of beginning to establish, you know, the kind of alliance which you need in order for therapy to take place, and the process of really establishing the alliance ultimately becomes the work of therapy in these cases, because sometimes when people, you know, are, you know, sort of fundamentally very distrustful and, you know, have a whole history of, you know, sort of not being understood by people, you know, by people in their lives or by therapists, and you know, haven't sort of learned adaptive ways of getting their needs met. And you know, these are the kind of patients who come into therapy where the real work involves being able to sort of, you know, sort of gradually work through these issues in relationship to the
Right.
point where, you know, the patient can begin to feel some degree of trust, and that's the work of therapy. So, you know, one, for example, you mentioned some of my training tapes. I did one 6-session training tape for the American Psychological Association, in which there were only 6 sessions, and the patient who came in, you know, was very kind of wary and mistrustful, and it was doubly complicated by the fact that, you know, we had 4 cameramen in the room, and
Yeah, that increases the need for more trust, doesn't it?
exactly, and so really what happened was, you know, for the first 2 or 3 sessions, it was really kind of touch and go, but you know, sort of ultimately, we sort of reached the point in the 3rd session where we were able to begin talking more directly what was going on, and by the sixth session, what had happened was that she had actually begun to feel a little bit more trusting of me and, sort of optimistic that actually, I mean, in this case, it was unfortunately, it was not going to be ongoing therapy, and I was concerned about her building up trust and then abandoning her. But still, I think it provided her with the experience of being in a relationship with, somebody who really can stick with her and work through these things. Then ultimately, I heard from her later on, she, went into a longer-term therapy. So, this whole process of developing the alliance in the first place can be a very important part of the work.
Right. So that creating that alliance is so foundational, really, to being able to do that deeper work, and then much of that work can be coming out of that alliance. So when you're talking about those, I mean, one of the other important things that I heard you say just moments ago was about there's those obvious confrontation ruptures, but there's also those withdrawal ruptures within the alliance, and ways you have some kind of markers for people to watch and to attend to whether that's happening. And it's obvious if they're not progressing in therapy, but there's some other much more subtle ways. And what are some of those markers that we should be watching for?
Right. So some of the markers of a more subtle withdrawal rupture can be, people will, well, this one is not so subtle, but people will, just sort of like shift the topic. You're working with a patient, and all of a sudden you've kind of lost track of where they are. And in those situations, often, therapists will just, they'll be a little bit confused, but, just sort of let it, where in fact that confusion your experience is a marker that there's something going on. And so at that point, if you just stop and say, wait a second, what just happened here? You may actually be able to get a sense that, the patient has, that you asked something that, made them feel quite vulnerable or made them feel criticized or attacked. There are other markers a patient can.
So there was two that you just mentioned, and one is an external marker where if you're tracking the content, where the client's going, and then the other was an internal marker for the therapist's own confusion, like how did we get here? What happened? So paying attention both to that, and I guess that's a really important part of the therapy of being a therapist, right? Being able, although many traditions don't teach that, for our paying attention to our own internal distress or affect, what's happening to us, and so hearing that from you, when maybe not everyone here has that tradition of using ourself as a tool there. So yeah, we can watch what the client's doing, but we also can pay attention to our own arousal states, our own places where we feel some disequilibrium in some way, some sort of confusion, and that those are important states ourselves to pay attention to.
That's absolutely critical. Yeah, just always sort of tracking your own feelings and experience and intuition. So, other examples will be, some sense that, you're just not feeling engaged with the patient. What's going on there?
Get me up. I need to go get a drink. Oh,
yeah, exactly.
I can't stay awake anymore. Oh, this client's coming. What do I do with him?
Exactly. Look, I mean, sometimes you've had a bad night's sleep and you attribute it all to that, but then you find the next client comes in and you're awake again, so it's always sort of an interaction. So I think, yes, if patients are sort of like cutting off or dissociating their own affective experience, because, well, there can be many reasons for it, but one can be that they're, feeling distressed about the relationship and reluctant to really sort of contact their experience. There are other more subtle markers. One is that, sometimes, well, actually not sometimes, we always feel that it's helpful to think of ruptures in the alliance as involving contributions from both the patient and the therapist, okay?
Yeah,
so, it's hard to know where things start, there's a way in which, when there is a rupture in the alliance, both people end up contributing in some way. So, if the patient is withdrawn, then the therapist can become more withdrawn. If the patient is kind of, sort of walling off and protecting themselves and, not letting the therapist in because they're feeling too fragile, well, then the therapist can be trying in various ways to kind of, sort of get in there and find out what's going on, right?
That's so interesting. I want to just slow that down for just a minute, because there are these ways that we interact. I mean, it's a relationship. We're interacting there. And one of the ways it can show up in us is I think about it this way. I don't know if you would quite agree, but if we're working to be in attunement and co-regulate in some way our client's experience, and they're really down regulating, and we're attuning to that, we can feel that our same felt sense, our mirror neuron system, we can really have that similar experience. But we could also do the opposite thing, and maybe it's us knowing a little bit of ourselves with particular styles of patients and clients, is that we can also go into face that wall and then move into our own affect regulation, getting more anxious.
Exactly, exactly. Or if you think of, sort of situation where the patient is sort of protecting themselves or defending against, an experience of threat or vulnerability, then what can happen is you can almost think of it like in couples, the pursuer-withdrawer dynamic, where, the therapist is like pursuing, sort of trying to get inside, and especially, if you think of a more emotion-focused or experiential perspective, you might be saying, what are you feeling? What are you experiencing? Anything going on right now? And the more you try, the more the the more the patient pulls.
They're gonna oh no, you're coming after me. It's the same dynamic I experience everywhere in my life, and oh no.
Exactly. And so the really critical thing here is for the therapist to maintain an ongoing process of, sort of being mindful and aware of what is emerging in the moment, right? Mm-hmm. So one term which is used is a kind of reflection in action, I'm doing something, and then I'm watching my patient's response to what I'm doing, and then I also sort of try to step back and try to look at what is it exactly that I'm doing, you see. So it may take a while for me to see that what's been going on is that I've been trying to sort of break in, and the patient has been protecting themselves, mm-hmm. and it can go on for a couple of sessions, and then all of a sudden I realize, wait a second, and if I say something like, if I keep saying to my patient, well, what's going on for you, they're just going to become more withdrawn. But if I sort of become aware of and accept responsibility for what I've been doing and say, you know what, I just become aware of the fact that it feels like, I've been trying to kind of sort of break in some way, feels like almost like I'm kind of hammering away, and I'm imagining if I were you, that would not feel very good. And then you say it in kind of a tentative way, but just sort of check it out and say, do you have any experience of my, sort of doing this, coming at you in some way? And in that way, if I accept responsibility for my own actions, then that kind of like validates a perception the patient has that they're not even able to articulate. Mm-hmm. And then that kind of like opens them up, and you can begin to sort of shift the dynamic.
So that's, if we're looking at your, we haven't directly gone into your repair model, but you're really talking, I think, about, identifying the rupture markers. That's your first, the first step, or first position. And then now are we talking about kind of recognizing and disembedding them from the relational matrix when you approach it that way?
Yes.
So that would be the second move in that, is after awareness, is then to find a way to bring it up, to share that responsibility. Sorry, go ahead.
Elaborate a bit on that. So I think the issue is that it's important not to think that, there's a rupture, you comment on it, you try and intervene, and then things get better. Because often what happens is that attempts to repair the rupture lead to another rupture. Okay, so what happens is that it's basically we take the perspective of both patient and therapists are always to some extent unconsciously or unwittingly participating in kind of relational dances without being fully aware of what they're doing. Now, sometimes that relational dance is not particularly problematic, right?
Right.
But sometimes it does become problematic, and then the therapist's task is to invite the patient to engage in the process of collaboratively trying to understand what kind of relational dance they're doing, okay? And so at this point, the process of like stepping outside of this, if you think of, again, couples, if you think of your relationships with your, sort of husbands, wives, mates, if you're having a fight, there's a way in which, there are certain regular moves that both partners have,
yeah.
And it tends to make things better, often just make things worse, right? So I think what happens is that by sort of intervening, watching the patient's response, sort of stepping back, trying to get a sense of what I'm feeling, and then stepping back and trying to, sort of step and look what's going on between us, eventually what will happen is that something opens up and I begin to see something I haven't seen before. Mm-hmm. Something changes, and at that point, if I'm able to sort of comment on it, well, first of all, just beginning to see something I haven't seen before, so beginning to see that I've been doing something that I wasn't aware of, and accepting that. So if I accept the fact, for example, that my patient says you're always criticizing me, and I don't think I'm criticizing them, and eventually I become aware of the fact, wait a second, I am critical of them. I guess I'm feeling frustrated. By accepting that and acknowledging it, that kind of frees things up inside of me, and then I can see what's going on, and that's the disembedding that takes place, and then my patient and I can begin talking about what's going on in a new way.
Mm-hmm. Right. So an important element of that disembedding is that as a therapist, I'm kind of stepping back and seeing the dynamic and seeing my contribution to that dynamic, so that helps me get back, I would say, in attunement or in some sort of alignment. That is a beginning of moving towards repair, because now I'm lining back up with my client's experience.
Exactly. And in the same way in which, in EFT, you're always sort of like trying to track the patient's emotions.
That sounds very step two-ish of EFT. Step back, look at the pattern, see the cycle, and disengage from it enough to re-engage in a different way.
Right. Yeah, absolutely.
Okay. So then you're ready to reapproach in some way to try to redevelop that safety with the alliance. So what happens then?
Okay, so there are different ways in which it works. Sometimes the process of what's exploring on between the patient and therapist, sort of in depth, can in and of itself be an important part of the change process in which, the patient begins to, they can become aware. We sort of speak about it. We use this term meta-communication, which means communicating about the communication that is taking place, okay? And we refer to that as a kind of mindfulness in action.
Mm-hmm.
Okay,
Mm-hmm.
so to the extent that the patient can begin to sort of observe what they're doing in the relationship with the therapist and how they're contributing to it, and also can contact feelings, expectations, and fears that they're not aware of, and begin to sort of express them, that in and of itself can be an important process of change. So if you take, for example, the withdrawal rupture in the patient who, has never been very good at talking about negative feelings to people, the process of sort of like taking a risk and standing up for themselves and seeing that the therapist is actually able to sort of like validate and handle that in and of itself can be a powerful corrective emotional experience. Right. Alternatively, with patients who have a tendency to sort of defend against their own vulnerable feelings and their need, and they have a history of being in relationships where, nobody meets their needs, and they have all this sort of like built up anger and resentment because of the fact that people aren't there.
They have to do so much on their own, and the only way they know how to try to fortify against that is with a more strong affect.
Exactly. So that they're like constantly, trying to get people to sort of meet their needs because there's this underlying feeling of desperation there, right? But they're not able to contact the underlying feeling of desperation. So in those situations, if the therapist is just kind of like able to hang in there, and kind of try not to respond defensively, and it is inevitable that as therapists we will at times respond defensively, but to be able to then sort of recognize that we have and acknowledge it to the patient and just continue to hang in there until the patient begins to see that, we're not going to abandon them, we're not going to be destroyed, then ultimately that can help the patient begin to access underlying vulnerable feelings that are being defended against. And when they're able to, in an affectively alive way, begin to talk about, what their real needs are and the pain underneath, that can be a very powerful corrective emotional experience.
Yeah, really, really powerful for them to have that. There's a question here from one of our participant viewers. Rich asked, do you ever tie what's playing out between the therapist and the client to the client's history to help them understand that contribution?
So yes, that's a very good question. The answer is absolutely. The client's history, anything you know about the client's current relationships, any information you have is important. The critical thing, though, is to sort of not take what you know about their history or the relationships with other people and kind of use it as a template for understanding what's happening in the therapeutic relationship. Because if you do that, that can blind you. It can be sort of done defensively and blind you to what's really going on in the relationship. So I think what I try and do is try and keep whatever information I have about the patient in mind lightly, right? And then there's a way in which, basically by really sort of like focusing on what's emerging in the moment, the pieces start to come together. But I have to be very cautious not to sort of like impose my preconceptions on what's happening in our relationship.
Yeah, that is so important, especially as you're monitoring the present process and being with them, that it's not, otherwise, I loved what you said, that it can become our own defense against feeling like, why are they treating us this way, or why can't we get through to them, or even some impatience that maybe they're not changing, or not helping them meet the goal as fast or something, and we want to get through some intellectual understanding. So there's that. I love how you're describing the tentativeness, and I think about it as I try to be with clients myself in that particular way of understanding, that there's this compassion that if I do have a little bit of a framework about what's happened for them, and I'm stepping back to see how am I fitting in, then it can also open my heart or my compassion to their experience, where it helps me take, I don't know, responsibility isn't the right word, but it helps me be with them. Yes. And approach them in a way that's different than their past, instead of just trying to get through to them something.
Yeah, absolutely. And I guess the other issue is that, sometimes, there's been a lot of research on interpretations in the psychodynamic tradition, and, when interpretations work and when they don't. And one of the issues is that sometimes, a really good empathic interpretation can be very helpful, but, often what happens is therapists, when they're feeling kind of stuck or defensive, can be making interpretations, saying, well, you're doing in your relationship what you did with your father.
Right.
A way of sort of subtly kind of saying to the patient, it's your problem, not mine.
Right.
And they feel that. They feel blamed, and they have good reasons for feeling blamed because although in part I'm trying to help the patient, I'm also sort of trying to take the heat off of me.
Yeah.
So it's very important to be cautious about that.
One more question, then I'd like to go through a little bit more of the steps that you've outlined for repair. Christy asks, what can we say after we are inquiring? If we bring something up and they say, oh, I didn't notice anything, between us, and they continue to withdraw or shut down.
Okay, so the issue is that if I bring something up and the patient says, I didn't notice anything, I don't know what you're aware of, it's important not to keep pushing, okay? Just to kind of sit back and say, okay, fine, and then look for other times and other opportunities, okay? Or the other thing that you can do is say, okay, well, it depends the sort of tone of voice the patient has, if they, sort of say, I wasn't aware of that or I didn't know it, you could say, well, I'll tell you what, next, I'm not completely sure what's going on either, but next time, if I see it happening, I'll try to draw your attention to it so you can, in the moment, we can kind of look at it. And so sometimes the issue is if you sort of try to talk about something that happened in retrospect, the patient is not going to be able to see it. Whereas if you draw attention to it as it's happening in the moment and, sort of tell them that you will, they're able to actually sort of observe it in that moment. However, having said that, it's important not to keep battering away. You just have to sort of like pick and choose your opportunities, and sometimes you just kind of have to back off and then wait for a new opportunity to emerge. And if you see the right opportunity and say it in the right way, at that point you may be able to sort of connect with the patient and get in there.
Well, that's a really important distinction, I think, because in some ways you're saying, it really has to align up with a therapeutic goal as well. And sometimes we may see something and think, oh, that's a good thing for them to work on, and that may not be what they're prepared for, ready for, really what they feel like their goal is. And so sometimes they will reject those in the moment or where we see as a way to go, because maybe there's some still unconscious place around that, but it may not also be the direct goal. And so I think sometimes we have to step back also and get back realigned with what is it that their goal is, what corrective experiences they're trying to create.
Absolutely.
Okay, one other question. I'm so glad people are asking questions.
Sure.
So can you comment about, from Kimberly, she asked, can you comment about ways to strengthen the alliance of when you have a pursuer client and a more withdrawing therapist, or vice versa, more therapist that's under stress, more automatic reactivity is to, close down, withdraw, and when the client active and protest.
Sorry, the video just, or the what's it called?
Oh, we had a little blurb, did we?
Can you say that again?
Yeah. Can you comment about ways to strengthen alliance when there's a
pursue
fundamentally pursue, withdraw, either direction, with the therapist maybe more withdrawing and the client pursuing, or the therapist more pursuing and the client withdrawing?
Okay, so let's start with the therapist who is more pursuing and the client is more withdrawing. So, in those kinds of situations, obviously, different therapists will vary in terms of this dimension to which they sort of tend to pursue, right? And that has a lot to do with, our attachment personalities, our, sort of personality structure. So for some therapists, certainly for me, for example, when I started doing this kind of work, I was very, very attentive to any little fluctuations in the therapeutic alliance, and that has to do with sort of, just personal experience, and sort of noticing if things weren't quite right and really kind of like wanting to get in there and fix them, okay?
Mm-hmm. Mm-hmm.
So I think, when it comes to that, it's really important for therapists to sort of learn what their own style is, and, if they tend to, sort of be overly intrusive, to sort of learn to sort of like learn exactly what that means about them, and to learn to kind of like sit back a bit and, sort of respect the patient's needs, and, sort of deal with their own anxiety about not really sort of knowing what's going on right
That's where
now.
the self-compassion and the mindfulness and the mindful awareness of self becomes so important, so that you know your automatic strategy, and you also are aware when you're, because it's not like we're always, I mean, maybe that's how it runs in the background, but we're not always under stress in some sort of a way that would, be hypervigilant, or if we are, we can, like you say, calm that down. So knowing that is so important. I think lots of us come in from traditions that weren't psychodynamic or psychoanalytic in some sort of a way, where we underwent a bunch of therapy ourselves. We have counselors coming in from different traditions, and so that if you haven't had that is so important to pay really good attention to those aspects of self.
Right. And then also, if I have a tendency to pursue in that way, that tendency of mine can be exacerbated with a client who has a tendency to withdraw. So again, it's just sort of like trying to become aware of what's happening between us in the moment, so that we can then, not just stop, but actually sort of talk about, what we're doing here,
Yeah.
As a way of kind of disembedding. Now, the other question which was raised is, well, what about the client who was pursuing and the therapist who was withdrawing? So I guess, there can be different kinds of pursuing. I mean, if the client is pursuing in the sense that the client is, sort of asking questions about the therapist or the therapist's personal life or whatever that feel invasive, that's one kind of pursuing. Okay.
Mm-hmm. That's right. Mm-hmm.
And here I think that you really have to kind of, if different clients will vary in terms of how much they want to know about you. And I think there's a way in which you have to, we all have our own levels of comfort with disclosing personal information. So it's important to take that into account. But also, I think that we have to, in some ways, pay attention to our sort of feelings, what they're telling us, because, one patient may say, are you married, or what did you do last weekend, or whatever, and it feels fine. Another patient may ask that same question, and something feels a little bit invasive about it. Okay?
That's right, right.
So it's important, first of all, don't, sort of take your feelings as automatically telling you this is what's going on, but it's still, pay attention to that feeling. And if it really feels like there's something kind of invasive about it, or if it feels like somehow the patient is, being invasive in kind of a hostile way, just sort of keep that in the back of your mind. Doesn't mean right away you should act on it, but, just keep it in mind that that may be important information about what this patient is like in relationships. On the other hand, if it feels like, sort of coming from a genuine place of wanting to know a little bit more about you so they feel more comfortable, that means something different. So there's that kind of pursuing, and then there's, sort of other boundaries such as, patients, if they want to have contact with you between sessions and
Right.
so on and so forth. Again, every therapist has their own level of comfort with boundaries, and that level of comfort varies depending upon who the patient is and what the nature of the relationship is. And then the final one, was it Christy who asked the question about pursuing?
Mm-hmm.
Okay, about pursuing is, well, the patient who sort of like is feeling desperate and they desperately want you to sort of give them something tangible or concrete, right? And you have a sense that nothing you give them is going to be enough. It doesn't matter if you give them advice or you suggest that they do something, or it doesn't give them what they want. So there, I think the issue is you have somebody who is like pursuing out of a sense of desperation, and the sense is to really begin to be able to sort of talk with the patient and meta-communicate about that. I might say something like, look, I really want to give you what you need right now, but I'm having difficulty doing that. I think there's a way in which, like, it has to sort of like evolve organically out of our relationship,
Mm-hmm.
and
Right.
so, I think that hopefully that'll give you some idea of how you can begin to work with that pattern.
Yeah, what I really love that you said, I want to punctuate, is that sense of noticing and being aware, but doesn't mean you have to take action right now on it. That you're kind of collecting data points or your own experiences in this relationship with your client, and at some point, you're going to step back and see, how does this fit in the picture? How am I involved in this? What is it? And then you can address it.
Exactly.
Okay. Okay, cool. So then we've been talking about noticing the awareness of the if there's a rupture, disembedding it from the relationship, looking at the relationship matrix there, and then what else? What's the third position?
Um,
I
so,
think it's about looking to what happens inside the client's construct of the
yeah,
rupture.
remind me, that's helpful.
Well, I've got my notes right here. So.
Okay, so yes, sort of noticing that there's a rupture, beginning to explore the patient's experience. I can use my own feelings and sort of in a judicious way disclose some of my own feelings as a way of beginning to explore what's going on. So often I don't know what's going on in the relationship, but I have some intuition which is difficult to articulate. So what I'll do is I'll say, look, I'm not sure exactly what's going on between us right now, but if you'll bear with me, I just want to try to put into words, I think there's some sense in which I'm feeling like, on one hand, I'm just making this up right now, but, on one hand, what you're saying right now, it sort of feels like, you're saying that you really, this is really helping you, and yet there's another level. Let me think of a better example. There's a patient who I worked with recently where he was constantly kind of very, very positive about everything that was happening in the therapy, and basically it just felt a little bit off. So, I said to him, look, I mean, on one hand, I'm really pleased to know that, this is helpful to you and that you're enjoying our work together. But on the other hand, it just sort of feels like it's a bit of a double-edged sword because, you're so positive that it feels like somehow there's no room for anything else, and so it's difficult in some ways. Like I feel like I can't really completely feel you, okay? And as I'm talking, I'm sort of, I may not know exactly what I'm going to say in advance, so I sort of try to try to articulate intuitions I have, and I'm watching my patient's reaction as I'm doing that, and their reaction is giving me feedback as to whether I'm on target or not, So if they're kind of like going yes, and they seem to be coming closer, I know, okay, I'm on target, and I'll keep going. If I see them starting to kind of pull away or withdraw, they start looking kind of like irritated, I'll stop and I'll say, wait a second, I can see that's not right. So beginning to articulate some of my own feelings judiciously can be another way of beginning to explore what's going on. The other thing that I can do is I can connect feelings I'm having to what we refer to as an interpersonal marker. So, I may feel, for example, that there's a patient who, the patient comes in. There's something about the patient that I really kind of like. I have a lot of respect for. I have a sense this person is really, really kind of like wise and very, very kind of like knowledgeable. And yet at the same time, I just sort of feel like I just don't quite know what I can say that's going to be helpful. So I may say something like, look, on one hand, I find myself really, sort of admiring you. I have a sense in which you've really sort of worked through some very important issues, and there's a tremendous amount of maturity. And at the same time, I'm just feeling kind of like at a loss, for what I can say that might be helpful to you. And I'm not sure exactly why that is, but I'll put it out there in kind of like a tentative way, and hopefully it'll open up, sort of a space for talking about, what it's like for the patient to sort of like have all these answers themselves, and it may lead into, sort of a sense of, well, I have to have all the answers because nobody else is going to give me the answers, or if I really depend upon the therapist, I'm going to be abandoned. So those are all, sort of examples of different ways of exploring what's happening. The other possibility is to comment on what may be a shared experience. So I say to somebody, it feels to me almost like the two of us are, and it may take me a while to realize this, but it feels almost like the two of us are kind of like playing chess in a way. I feel like I'm trying to take your, sort of queen or your king, and you're trying to protect it. Do you have any sense of what I'm talking about? Does it feel like that at all to you? And then the patient may say, yeah, I guess I can kind of see that. And so then I can say, so what does it feel like to be in your position right now? And the patient may say, well, I feel like I'm constantly having to protect myself. I'm constantly having to protect my queen or king, or so. There are a range of different ways in which we can begin opening up.
Well, there's some similarities in the examples that you give, and one are using your own felt sense, I think, your awareness and your felt sense. The tentativeness, maybe, and one of the, I want to ask you about this. I'm not sure if this is really what I heard or not, but so your awareness of your felt sense and the relational dynamic, and then coming in pretty tentatively, and then maybe you can also use some present process thing that's happening as in it, like that's another way to do it in the moment while it's happening versus, oh, there's this dynamic that's been kind of ongoing. But I wanted to ask you about that confusion kind of as a marker. It's certainly something I've experienced, and you mentioned it when you were starting your first example, about feeling kind of confused. And I wonder if this is, as I formulate the question, I might actually come across the answer at the same time. So let's see what happens here.
That's just
something
like
about that can.
patient.
That's right. Here I am in therapy right now.
Yeah.
Somehow that confusion, when we have that bit of distress, confusion as a marker, and then you said it can be hard to, like, that's pretty important. If it's hard to find the words and it's hard to organize, that itself is an important marker and a great way to bring up, because it has that tentativeness with it because you don't, there is a knowing around it, that's really kind of leading with our own vulnerability in a way that increases the safety for the client. I guess that's kind of the question.
Well, you said that's a critical point that you just made there. You know, accepting and leading with our own vulnerabilities. So, yes, first of all, you know, confusion in the therapist is a very important marker. Often, as therapists, if we're feeling confused, we just kind of somehow they try to ignore it, you know. And so there's something about recognizing, wait a second, I'm confused. What's going on here? You know, and sort of like stopping and trying to track what's happening. But the other thing related to that is, you know, sort of, it's very important for me to be able to sort of accept and acknowledge my vulnerable feelings. Okay, mm-hmm. So I think, you know, to the extent that I'm able to, it's almost like, you know, like there's, you know, there can be sort of like an elephant in the room, you know, which is that, you know, the patient is, I have this feeling that the patient, you know, sort of is, feels very kind of like critical of me, you know, and that nothing I say is, you know, going to be right, you know, or that the patient is, you know, sort of like feeling patronizing to me. And to be able to actually sort of like put that out there, in some sense, lead with my vulnerability and say, you know, look, I just have a sense that, you know, that, you know, that I keep making mistakes or something like that. By putting that out there, that kind of like frees me up, because sometimes it's kind of like not being able to admit and acknowledge my vulnerability keeps me stuck, you know, yeah. or I have a sense of, you know, I just, this is kind of strange, I'll say, but I have a sense in which, like, it would be very easy for me to lose you, you know, that I could imagine, you know, you're just kind of like walking out and not coming back. You know, so I have to steer in the back of my mind that, and it may not be completely conscious, that, you know, somehow unless I'm performing perfectly, I'm going to lose my patient. And that kind of ends up kind of like, you know, sort of, straitjacketing me, you know.
Right.
So that out there, you know, by saying, look, I just have to sense, and I know it may just be me, but it's like, you know, if I say the wrong thing, you won't be coming back, you know. Well, sometimes the patient will say, oh, that's not true, I don't know why you'd say that, you know, and that's always a risk you take. But sometimes the patient will say, well, yeah, I suppose, you know, there is some sense in which I don't, you know, sort of, yeah, I am kind of, you know, sort of not sure whether you've got what it takes or something like that. And I can say, okay, can you talk more about that, you know? And then the patient can be more upfront with their sense of their lack of confidence in me and their sense of, you know, sort of evaluating me very carefully.
And that is a process of repairing and strengthening the alliance, because the client can begin to show up more and be more expressive themselves with us then.
Exactly. And if where the patient is, or where the client is basically, you know, sort of feeling critical of me as a therapist, or feeling like I don't have what it takes, and they're not saying it, then they're not bringing themselves into the therapy. So there's something about being able to really sort of like bring that into the therapy, which allows them to start engaging.
Right. Well, I'm noticing the time, and it went like way too fast. I thought we had 20 more minutes, and we don't. So I want to refer people to your book, and also they can look up your art. They can look up your article. Maybe we can even provide it in the post-production page on the supervisory process, or I refer them to your book. I think that's probably the best. I'll put that in the chat box, a link to that on Amazon that they can go directly to. And that on Alliance, that's such a fantastic book. It's just everyone needs to have a copy and be studying it. I want to thank you so much for being here on and sharing your expertise. It's been so much fun to be with you, and I so appreciate your perspective and your research and the way of privileging using ourselves as a tool, because that is the relational dynamic that people end up having correctional emotional experiences with, and creates recovery, which is what we're trying to do, is help that healing. So
Well, thank you, Rebecca. I really enjoyed talking with you, and I enjoyed your questions.
okay, thanks so much, and we'll be back in touch. Thank you.
Okay.
Bye, everybody.
Bye-bye.
Thanks for joining us, and next month, I think it's December the 9th, I'll be on with Lori Scatty. We'll be talking about using warmth in couple therapy. Thanks.
Bye-bye. Thank you.
Bye-bye.